Okay, so today's primary topic of today's session on the pharmaceutical industry will be marketing practices. And conceptually, this is pretty simple compared to the whole patent story and way simpler than trying to understand the PBM sector, which is so important to understanding the big picture. But we're going to focus primarily on marketing. I did want to start out, however, with talking about who does research at different stages, since it has impacts on marketing. So let me pull up some slides. Okay. Okay. So I wanted to talk a little bit about who does the research at different points along the way. And most basic research in the country is funded through the National Institutes of Health, typically done in a university setting, and disproportionately in major cities and at major research centers. So Mass General and the Massachusetts Institute of Technology are major funders. Boston itself has a very large portion of research funding. It may be as much as 25% of all NIH research is done at one or another of the Boston facilities. And then New York City and some other major research centers get a good portion of the rest. But now this is all before the cuts that the 40% cut in the NIH budget that we saw with the Trump regime in power now. Anyway, so most basic research is done at university centers and a small portion of it at the NIH itself. And they may fund all or part of a professor's salary, the researcher's salary. And then if there seems to be an entity, a drug entity, that is promising for something that could be a usable drug. In other words, it seems to be safe and effective for a specific disease process. At a certain point, there's an economic event happens, a financial event, and it's called the spinning off, that you'll take a professor doing work at a university with NIH money, and they'll be the spinning off to create a for-profit entity. And this is what you could call the corporate welfare step, where the government has paid for for important research, and now it's going to leave the aegis of the NIH and be privatized. So typically there's a partnership between the university and the professor to create this spin-off entity. And that entity is really looking to be bought up by a pharmaceutical company because they're going to get paid a whole lot of money if that can happen. On occasional instances, the spinoff itself, either because nobody wants to buy them or because they think it's such a great entity, they may try to find a way to stay and remain independent, maybe to develop the product further and do some of the testing themselves because they're so confident it's going to look good, and they'd rather be bought up later by a company that can actually produce the product. And then very occasionally they may even try to manufacture a product, for the retail sector, but that's less common. So the spinoff, once it looks promising, a pharmaceutical company could buy it up. And at that point, the site of the research changes. So now, instead of the research taking place in a university setting, now the research is not even going to be done by the professor who developed it most of the time. But now the pharmaceutical company now bought the product, bought out the spinoff and absorbed it. And the pharmaceutical company generally is going to use something called a contract research entity or contract research organization, a CRO, to do the remainder of the research, which is often the entire phase 3 research, which is the big step. Phase 3 is the big step where you're getting into a somewhat larger population, enough of a duration of the research so that it could be marketed. And the goal of phase 3 research is to submit it to the FDA to get their approval and then market the product. And the key thing about contract research organizations is that this is very divorced from the university setting. They're doing the research they're assigned. Um, they they're completely employees in the sense of the pharmaceutical company is in control. These CROs are there for a specific reason. If the pharmaceutical company wants to write up the research, they will, and they usually do. And they'll slant the research, they'll slant the write-up in the best possible way. And you heard about some abuses where even the original duration might be a year, but if the product looked more favorable at 6 months, they might just present the 6 months in the research paper. And the CRO doesn't say a word because they're just hired hands. So this is very different from a university professor who's, presumably has more integrity and may have other ideas and, not want to present research that's might be misleading. So it's an important step. There is, however, something called phase 4 research, and that occurs when the FDA says, well, the paper you presented only has 1 year of data. And we did see a couple cases of pericarditis. It's a little more than we might expect because that's a rare disease. So, and we'd like you to extend the research further and resubmit to us in another 2 years or 3 years to continue collecting data. But often that's violated, and it often doesn't happen. But at any rate, so one reason phase 4 research might be done is the FDA actually required it. But anyway, to look for, again, often to look for a specific side effect. But there's a whole different type of phase 4 research, which is initiated by the pharmaceutical company itself. And this is actually pseudo research. And the entire goal of it is marketing. So when a drug is new, you have to break through into the brains of the doctors who are prescribing it. So one way to accomplish that is to give the doctor some samples and some money. So the doctor might get paid $1,200 or $1,800 to prescribe this drug for specific conditions, like say high blood pressure. And then there'll be like a little questionnaire. It's usually pretty short. Did your patients notice any side effects? Would you prescribe the drug for your patients with whatever the disease is? How efficacious did you find the drug? And this is never going to be published, but the doctor's getting paid, the doctor's getting samples, the doctor's getting used to using the drug, say it's for high blood pressure. The doctor's used to using it. So the goal of the pharmaceutical company is twofold. One is to get the doctor used to prescribing the drug for this condition. Nobody involved is saying this drug is better than the older drugs that it's competing with, but it's getting into the, its doctors starting to use it. The doctor might talk about it with other doctors if they're lucky. But the other thing that's going on is the doctor uh, might feel gratitude toward the pharmaceutical company and feel, well, they gave me $1,800, um, so I feel like prescribe I should prescribe this drug. And so they go ahead and prescribe the drug more often. And now the patient's having to actually pay, or the pharmaceutical company's getting paid, and the amount of pay that the pharmaceutical company gets is usually really high. This is a new drug, it's under patent, and the pharmaceutical company in the United States gets to set the price. And as you know, they tend to set it really high. So this works out to be a really good deal for the pharmaceutical company. Um, and one key defect in FDA regulation is that there's never a requirement to compare the new drug that you're putting on the market to the best available treatment rather than a placebo. So we have multiple forms of minor tranquilizers on the left side, and over here on the right, these are all various ACE inhibitors that are all pretty much doing the same thing. And it also becomes confusing with different doctors using different drugs because you get used to the dosing for one of them, and the dosing for all the others is very different. So captopril, typical dose might be 150 milligrams a day, but for lisinopril, it's only 20 to 40 at full dose. So it becomes confusing to try to keep track of all this. So another issue with pharmaceutical research prioritization has to do with need versus demand. Need might be public health significance, so we desperately need better malaria treatments, but the people who get malaria are generally poor. They live in countries with little market power. So this presumably wealthy woman who doesn't sleep well, the 10th product for insomnia or 15th will get researched rather than a life-threatening illness like malaria. So they're looking for paying customers. You can call that demand. You have demand, consumer demand means you have money. You're bringing money to the table. It doesn't, even if millions of people have malaria, they may have no demand because they have no money. So, so pharma is really kind of a marketing machine. Here's the breakdown of how they spend their money. That 27% is all that's needed for manufacturing the medication. Marketing and administration is 35%. Research and development only 13%. 7% for taxes, and then 18% for profits. So it's one of the most profitable sectors within the economy. And despite the constant claim of the pharmaceutical industry that they do all this research, it's actually a fairly small fraction of their budget. So this slide I'm going to show you several times. This provides the array of marketing strategies that pharmaceutical companies use. So the first one is direct to physician. They used to call them detail man because before I was practicing, there were some men. There were all men. And then that changed in the 1980s, and now it's typically young men and women who conform to conventional Western beauty norms and use the standard strategies of flattery, giving gifts, giving dinners, trying to get medical students to accept gifts, because when you accept gifts, you feel gratitude, little bribes. This has been studied psychologically, and even if all you're given is a pen or, something relatively small, reflex hammer, you still you're left with positive feelings and toward whoever gave it to you, and you'll have, regard that drug company, their product, whatever, in a favorable light by little bribes. So the direct to physician, and then that phase 4 research is typically not done by experts, but it's actually done by grunt doctors too, who meet a detail person, man or woman, and they get offered this phase 4 research. And apparently heavy prescribers are sometimes even given bigger things. You hear about trips to the Caribbean on a cruise funded by a drug company. Anyway, so that's the first thing, is direct to doctors and other prescribers, nurse practitioners and PAs. So the next one is medical school professors. And their research, they're hoping to get bought out. So Pharma now funds over half of university-based research. This is the half of it that is applied research. It's virtually never basic research, but sometimes the pharmaceutical company, in other words, funds the doctor while they're still at the university. And then at a certain point, the whole thing may get privatized and bought out, as I said earlier. But often the research at the university can also be funded by pharma. However, when they're doing phase 3 research, usually that they want to get a contract research organization, since they have more control over the study in that sense. But when you go to hear speakers, a lot of times who are university professors, they'll all list connections with drug companies, because drug companies do fund a lot of the later stages of research when it's moving toward getting toward an actual drug entity that they might be able to market. So the next step are thought leaders. The pharmaceutical companies identify people they believe to be thought leaders. So a university professor could be a thought leader, but maybe they're earlier in their career and they're doing research that looks really good to the pharmaceutical company, but they don't have the reputation or the panache and the charisma to be an actual thought leader. So the pharmaceutical companies try to identify thought leaders who are going to give talks to physicians, and they actually can give them slide sets that they call a speaker. I can't remember, speaker training. It's like a kit that they give where there's beautiful, beautiful slides that kind of end up highlighting their drug, even if it's supposed to be in a setting where you wouldn't want that done. So there'll be a pharmaceutical company speakers bureau with these thought leaders. And these two researchers actually looked at this strategy by the pharmaceutical companies of trying to persuade other doctors to buy drugs by hiring a speakers bureau, and they give them a whole lot of money to give these talks. You'll get like $10,000-$15,000 just to give one talk, depending, on how well known you are and your reputation and how favorable you're going to slant your talk. So speaker teacher kit, that's what they call them. And basically it's slides created by the pharmaceutical company. So far we've gotten through direct to physician, university professors, and thought leaders. And now we're getting to clinical guideline panels. So in other words, there is a lot of research done on almost every topic, like in primary care or internal medicine. A lot of the drugs I use will fall into specific categories, like how to treat type 2 diabetes, how to treat hypertension, guidelines for how to treat seizure disorder. So the reason there are guidelines is because if there's 15,000 research papers coming out every year on epilepsy or seizure disorder, I can't read them all. I just can't do it and also be able to maintain a certain amount of expertise in everything else I treat, treating diabetes, treating hypertension. So I'm relying on clinical guideline panels, experts who are going to go through all that literature and keep up on it, and then create a guideline. So an initial treatment of partial complex seizure should be with a certain drug because it seems to be the safest and most effective. And because I can't possibly read 15,000 papers in each of the fields that I prescribe in. And some of the research may be low quality or, low sample size, or they didn't follow the patient for very long. And other research may be much more important. So I'm relying on these guideline panels of expert doctors to come up with recommendations, which I generally follow. And they're so important that when I deviate from them, if I were to actually somehow get into a malpractice suit and I deviated from a clinical guideline, I would have to find some way to justify it. Anyway, so they're very important. And these people on these guideline panels, unfortunately, are often connected to pharmaceutical firms one way or another. And the pharmaceutical firms really look for ways to funnel money to these people to gain favor. Okay, so then you go to CME, and you guys are just your first half of medical school, so you don't know this problem firsthand, but I haven't been to medical school in some decades. So, and I'm still working. So I have to maintain my knowledge base. And Dr. Keller mentioned she didn't get very specific about what she was talking about with the 50 credits, but this is what she was talking about: continuing medical education, CME. And generally, to maintain hospital privileges and to maintain a license, I have to spend 50 hours a year uh, on ongoing education to keep my expertise up. Now, informally, I spend a lot more than that because I get all these medical journals and I read them, um, just different times when I have some extra time. And so uh, ongoing education is extremely important. And there's sort of two varieties now. The variety you do by yourself, like taking a test, get a medical journal, and they'll give you a test on the articles in the journal. But there's also uh, conferences. And the reason why conferences are important is because you get to interact directly with experts, and in reading a journal, there might be some article that's not it that deviated from what all the other research is showing, and so it's not really representative. So the same kind of people who would be on clinical guideline panels will be participating at CME events. Oh, and by the way, for the guideline panels, here are different people on the cholesterol guideline panel. Um, all these names and all these drug companies they're connected to. So anyway, moving on to CME as I was trying to do. So at CME, these events, these conferences that you kind of need to go to, um, you'll you'll see these disclosure policies that, okay, let's say it's a conference of my professional organization, which is called the American College of Physicians. Turns out the ACP is only internal medicine. That's what it is. It's kind of misnamed. Anyway, so they'll have a disclosure saying, in accordance with the disclosure policy, the medical school is the standard set forth by the Accreditation Council of CME. Course planners have been asked to disclose relationships. So they don't have speakers that don't have relationships with drug companies, but they have to at least disclose them. So nowadays there are disclosures, but still, that doesn't mean the person's objective if they're being heavily heavily funded by a pharmaceutical company. And they've been asked to list off-label uses of pharmaceutical companies because they're not supposed to do that. You're only supposed to prescribe a drug for what it was researched for and research that was submitted to the FDA for approval. So anyway, that's been a big strategy of drug companies to get you to prescribe for non-approved indications. In other words, a seizure drug might help with neuropathic pain, like sciatica, but maybe it won't, and there might be some doctor who says it works, who's an expert, who says, well, I've prescribed that for neuropathic pain, it works really well, but it never been studied, and technically they're not supposed to do that. So this is a picture. Anybody know what this is? This is a picture of? It's at a medical conference. What do you think it is?
A poster session?
Yes, it's a poster session. It's exactly what it is. It's a poster session. And what's going on here is that typically early career researchers will submit their research, either when it's complete or when it's nearly complete, to say the American College of Physicians or American Academy of Pediatrics. They'll say, I'd like to present this at a poster session, and they'll be given that much space. It's probably 8 or 10 feet of space on the edge of the conference. And they present their research, and the people attending the conference can go look at this research. And usually the early career physician or the resident or fellow who's presenting their research will stand there by their data in case the person looking at it has any questions. So it's genuine exchange of ideas about new research that's just been done. So it's great. But, they're all getting these little booths, population of other little booths, and looks very different than this. That's the main part of the conference. And what you're seeing here, it's almost like the difference between the Soviet Union, and everyone else. They had these bleak, pictures of how everyone lived and all the houses look the same. But here you are over to the capitalist country, and in fact, you're getting the capitalist pharmaceutical companies buying up space to put their exhibits. And the flow of money from the pharmaceutical company is going to the conference center, which might be a hotel, big, fancy hotel in a big city, or like the Philadelphia Convention Center in downtown Philadelphia. So the pharmaceutical company will be paying for the amount of space they get. And part of the money goes to the American College of Physicians, and they may subcontract it. Maybe all of it goes to from the drug company to the American College of Physicians, who then pay the hotel for the space. So money starts at the pharmaceutical industry, goes to the sponsoring organization, which is often a professional organization like the American Academy of Pediatrics would be a good example. And they're getting money from the pharmaceutical company. And the pharmaceutical company, what's in it for them is the American Academy of Pediatrics is well respected. It's the main organization representing pediatricians and the ongoing education of pediatricians, the CME. And so the pharmaceutical company gloms onto that reputation. They know there's going to be a lot of pediatricians there at the conference, so they'll have expensive new drugs that they want the pediatricians to start prescribing, and that's who will be there showing up to create these fancy colorful spaces. And, so here, this is a more modest one. Uh, AstraZeneca, which has done some work in hematology, and they'll be promoting their job. But, even this is more modest than usual, but this is a lot more space than one of those poster sections. And here are some of the more generous ones. So this actually is my conference. This is internal medicine. And I don't even know what these drugs are because, they're all what are called Me Too drugs. You talked about that earlier. A Me Too drug is just another, the seventh ACE inhibitor or something like that. And I know I'm never going to prescribe it until it becomes generic because, there's 6 drugs that are already generic that are less expensive for my patients. So typically these are drugs that I don't prescribe, and I usually don't spend really hardly any time because I'm not going to learn anything useful. And there's also some device people here. It might be a new sleep apnea machine that they might be promoting. So they might show up too and be spending this kind of money. And typically at these booths from the pharmaceutical companies, there'll be food, they'll give you popcorn and, candy and other kinds of stuff, cotton candy, whatever. Anyway, so that kind of goes on. They're bribing you in different ways and giving you papers to read that slant their drug in a favorable manner. And that's pretty routine. Almost everybody's giving something away. It's usually food, could be pens, other kind of knickknacks like that. And here is a particularly big one. Again, I don't even know what these drugs are. Um, booze, they'll just do different things to entertain doctors going on. So you can see that the CME is heavily funded by pharmaceutical companies. And then pharmaceutical company also turns to be an important source of funds for medical journals. And the classic way this was done was after an article is published, uh, the pharmaceutical companies will ask to buy 5,000 what are called reprints. There's basically a copy of the article in kind of glossy paper. And it's inflated. And the medical journal charges a lot because they know that it's going to be mainly the pharmaceutical company who's going to buy it and that they have a lot of money. So it turns out that selling these reprints is an important source of their funding for a lot of medical journals. So it may taint their coverage. Like if there's an unfavorable piece of research coming out on that drug later on, it may be that they've received so much money from the pharmaceutical company that they'll, be hesitant to publish it, or they'll ask for more supportive data or something like that. So they're basically currying favor with the medical journals. And then, so here you are with drug ads. That's the other big one, is that they'll put these beautiful drug ads into the medical journals and to try to influence physicians who are reading these journals. So they buy reprints, they put in ads, and they curry favor with the major medical journals. So then moving on to their support for, oh, by the way, I don't want to skip this one. So down there in the corner of this slide is conflict of interest with the FDA, in that many FDA employees who are not paid particularly well will then take jobs with the pharmaceutical sector after they leave the FDA. So right from the start, they're expecting that private sector job where they may earn 3 or 4 times higher salary. And so they're going to tend to have a favorable attitude toward pharmaceutical company. And also now the pharmaceutical companies are now funding the FDA. That started in the 1990s. Before then, it was taxpayer funded. And now that there's heavy user fees to submit a drug to be reviewed by the FDA, the FDA is under pressure to get them through. Like the pharmaceutical company said, we gave you all this money to review our drug, get it done, move it, and so it's kind of a conflict to get the drug through and approve it. Okay, so the next one is they also fund patient advocacy groups, such as the American Heart Association and the American Diabetes Association. So let me try to move to that. So these are a list of all the companies that have been supporting the American Heart Association. And there's huge numbers of drug companies and that have donated. So these advocacy organizations, like the American Lung Association, the American Heart Association, the American Cancer Society, the arthritis, American arthritis, whatever it is called, there's one for arthritis, an advocacy group. And the idea is that patients who have lupus might join this National Lupus Organization where they can learn about their disease and get new information and get into a support group with other people who have lupus, who are dealing with all that lupus means and how it disrupts your life. And so it's a support group and it's a place where people can learn more. But if they're heavily funded by pharmaceutical companies, you can imagine that the information they get is somewhat biased. And furthermore, the patients who get involved with, say, the Lupus Society can then be recruited by the drug company to testify in case there's in case the drug company is having trouble getting insurance companies to cover their product. They can actually get patients to advertise. This particularly happens for extremely expensive ones. So, for example, a drug company developed an injectable treatment for, I think, macular degeneration or some very terrible disease that causes blindness frequently, or some rare genetic one. There'll sometimes be that one, extremely expensive drug, $1 million for like one dose or something like that. And they'll find people with the disease and pay them to testify before Congress that this drug, absolutely must be approved and it must be funded by insurance companies. And so it's just another way to get public relations to sort of curry favor, buy favor, and identify people who might be sympathetic to them. So really, these are really long lists of companies that just donate, and that's just the American Heart Association. So, and then the final one, so the advocacy groups, and then the final one is direct-to-consumer advertising, which was not allowed in the US until 1993 or 4, something like that, where they started allowing it. This went through the judicial system, and the judiciary said, yeah, you can't suppress free speech. So now pharmaceutical companies spend a lot of money on drug ads. And you guys are on Instagram a lot, it sounds like, and maybe TikTok. I don't know if it's there, but if you watch a conventional news program, like the ABC Nightly News, almost all the advertising will be from pharmaceutical companies because the market, the people who watch cable news, like the ABC Nightly News, are elderly, typically. That's the demographic. So a lot of those expensive ads are going to be on those shows that they know have a lot of older people. And so, but anyway, there's a lot of drug ads throughout television, but particularly news programs, which elderly people watch. And so basically, if you look at this slide, um, and this is what goes on, by the way, in the direct-to-consumer ads, it's always ask your doctor. Like, ask your doctor. You may be a man, a few words. That's an ad for Viagra on television, you for erectile dysfunction. And this one I've never even heard of, arbitrar. I don't know. I can't even tell what it is. Anyway, these are, typically prescribed drugs that I don't need to use. They're new drugs. And also another issue with new drugs, I don't know if you got this sense, but phase 3 research doesn't really go on long enough. It's like, it might be a year, but I'd rather prescribe a drug that's been around 10 years. So I avoid prescribing new drugs, unless there's really something special. And I like to read about it in more than one place. And they're expensive. So anyway, direct-to-consumer ads are a way to get patients to sort of ask the doctor for something, since the pharmaceutical companies, their marketing departments classify doctors. In there's one group of doctors are the intellectual types who need to see research. Another types are the inflexible people who don't change what they're doing. But the group that they like the most are the innovative, like doctors who want to feel innovative and who like to try new things. And they try to find those doctors because they tend to be the most willing to, try out some new drug, even if it's expensive and not fully tested. So I'm in like their worst group. They hate me. I never, when I was still working, before we banned pharmaceutical reps from coming to our clinic, I was like, they didn't want to see me anyway because they knew they have access to my data. They can look at the drugs I'm prescribing and they can see that I don't prescribe new drugs. So they sort of ditch me. Like they don't even want to talk to me. Zach, go ahead.
I just wanted to ask, I know we've learned that drugs under patent are the most expensive for our patients. How often do doctors really take into account cost when they're describing or when they're deciding which drug to give to a patient? Like, is that something you do because you're so educated on everything, or is that something like all doctors try to do? Yeah.
Yeah, I'm a biased sample for you to ask that question to, but it's my experience. So I've worked at community health centers, at hospitalist groups. I mean, I guess I'd say that hospitalists, they're prescribing inpatient drugs, so it doesn't come up as much. Like the control over inpatient pharmaceutical costs is done by those who create the formulary at the hospital. So every hospital has a formulary of drugs. And if there's completely two duplicative drugs, they'll only have the drug they're getting at a lower price if their efficacy is totally identical. So, but you're right, hospitalists do sometimes we often prescribe the end of a course of antibiotics after patients leave. That would be a common one. And yeah, I guess I think it's mostly in primary care where much of the prescribing goes on. And like a neurologist, for example, who is prescribing drugs for multiple sclerosis, they'll probably know which drug for MS is going to cost like way more. And so I think I think this is not an all or nothing answer. I think there's a lot of understanding. Patients, I even think believe people who would be politically conservative may well try to prescribe in a cost-effective way. And if you look at the international data, the US does better than almost all the other countries at prescribing generically. And I think it's because it's sort of become part of our culture. Even at conferences, even these speakers who are, funded by pharmaceutical companies, they'll often mention that this drug's generic and it's, and it works. We don't hear, even these people are biased, they typically don't heavily appear to be promoting an expensive drug. I think the pharmaceutical companies have multiple reasons to want to give money to thought leaders, though. Uh, to get their drugs researched even, they're looking for somebody who's gonna, who's well known to do the research and who attracts research grants. So it's there's a lot of, you know, uh, benefit on both sides of these equations. But I think the bottom line, yeah, I was going to show you this ad. They got one of the greatest basketball players in history to get onto the circuit. Anyway, let me finish up though, because I wanted to end a little early so we have time for questions. So the bottom line here is going back to this slide, that this is what you could call, speaking of basketball, a full court press. This is an industry with so much money that they can spread it around. And they do spread it around. They want everybody they're currying favor with every single grouping here, every step of the way. Doctors, professors, thought leaders, guideline panels, their money is insinuating itself into every part of the physician education and CME, especially continuing medical education, but also, they'll try to get themselves into medical schools by, making deals with professors as well. So this is their effort, is to try to get prescribers interested in their drugs and feeling obliged to them. Like once someone gives you money, you feel some sort of obligation for them, and that's what they kind of want. So and then, but more important than anything else, nothing matters more, is the lobby. Because if Congress didn't get lobbied, then in a day we would have negotiating going on. And potentially we could even do what Canada does, which is the government negotiates for all the prices, even though it doesn't even cover drugs. The Canadian healthcare system doesn't actually cover drugs as part of the Canada Health Act, but it just covers drugs for elderly people and poor people. But they negotiate down. And so it's the pharma lobby in the United States that makes all of this possible. When Obama tried to pass Obamacare, they put out these Henry and Louise ads. See if I got one. They put out these Harry and Louise ads, which were opposing Obamacare, and they had done that to Clinton in the 1990s, and they were about to do it to Obamacare, but he gave in to everything they wanted. So Obama was trying to get the pharmaceutical companies to lower prices, and they did it in a way that was fake. They basically said, yeah, we'll reduce drug prices by $80 million in the first year of Obamacare. And what they did was they threatened to raise it more, and then they cut off $80 million from the price rise that they did anyway. So it was just the pharma lobby that got them to do that. So anyway, I think did Ken tell you about the Bayh-Dole Act? So the Bayh-Dole Act was passed in 1980. It was supposed to spur research and industry throughout the U.S. economy and after the stagflation of the 1970s. So they were going to allow even drugs to be researched at public expense and then given to the pharmaceutical companies, which we looked at earlier in this talk. And patenting of publicly funded research would used to remain in the public domain and couldn't be patented, but then they allowed them to patent it only if the drug were made available to the public on reasonable terms. And the government reserved the right to march in and start producing the drug itself. And this could have been done during the pandemic for many products, but also pharmaceuticals, and it wasn't, but it could have been, to say that we need to have this drug available for everybody at the lowest possible price. And this is a pandemic, so we're not screwing around here. We're going to get this produced at the lowest possible cost. And they never did that. So the vaccine for COVID is still very expensive, well over $100. And they were supposed to track the patents obtained from publicly funded research, and excessive royalties. In other words, profit was going to be returned to the government, but none of that ever got enforced. Even though this idea of giving this corporate welfare of giving over a patent to the private sector, yeah, that's happening all the time. That's routine, but the government never cracks down and makes sure these drugs are provided to the public at a reasonable cost. And again, all of this is due to pharmaceutical lobbying, so that's kind of the bottom line. Anyway, so that's what I have about marketing. Conceptually pretty simple. You got a lot of money, spread it around, keep everybody loving you, and keep your profits coming. Any questions, thoughts? Yeah, and Anna, go right ahead.
Um, as you were presenting this, I was thinking about big tobacco and how they limited advertisements legally and, on television and even on like trains and in public settings. And I'd assume that big tobacco also had really big lobbying power back, I think that happened in like the 70s or the 80s.
Mm.
So I'm wondering if regulations similar to that could be put in place here in terms of pharma marketing and help decrease the impact of lobbying from pharmaceutical companies.
Are you trying to limit lobbying or advertising to the public? I guess I lapsed a
Both,
little bit.
ideally.
What'd you say?
Both ideally.
Uh,
Uh, but I guess lobbying is such a behemoth power, as you were saying. So I guess we should tackle that first. But I wonder, do we think the lobbying is even greater than the influence that big tobacco had back in the day?
um, I that's kind of a hard question to answer because they both did really well. But on the other hand, the tobacco industry lost
Mhm.
largely. It took a lot. That battle went on for a long time, and a whole lot of effort went into it to defeat the tobacco lobby. The problem, the problem fighting the pharmaceutical industry is that their product is not as exclusively harmful. Like even the firearm industry, like it looks pretty like especially when it comes to assault weapons, I don't get it, like why those are legal military weapons. But at least you can argue that a firearm has some positive use. For those who feel safer when they have one, or for people who hunt. Um, but pharmaceuticals is a big advantage because they're saying, oh, this drug's helping all these people, whereas tobacco only had negative results. Like there's never a kid who's, well, even though there's a limited number of people who need a drug for multiple sclerosis, but those people really need it. There's never a child you say, yeah, you really need to start smoking. It'll help you, something or other. It's just exclusively harmful. So that was kind of an advantage. On the other hand, it didn't have to go this way, and it doesn't go this way in other countries. And I guess now, I mean, we talked about social change at different points, but this is kind of heavily in the Supreme Court's docket. This is not, it would take a lot for the legislative branch of government to come up with something that the Supreme Court would allow through, because they're very heavily on the side of big money being allowed to spend it the way they want to, because the equivalence between big money and speech is now total for the Supreme Court. Like if you have the money to buy an ad, nobody can stop you from buying the ad, because that would be suppressing free speech. So this is now heavily in the judicial branch of government to try to do something about lobbying in general, including pharma lobbying. I don't, what I actually would want to know is if some of the limitations on tobacco advertising, if it went to this Supreme Court, if it actually might get reversed. Because they're that far on the side of free speech. I'd love to know that, but I hope it doesn't happen for the sake of the public health. But anyway, any other thoughts?